All right, let's jump right in. We're going to be talking about a very specific, really powerful tool, vasopressin, and how to use it in one of the toughest situations we face, cardiogenic shock. And look, this isn't about using a sledgehammer for every problem. This is about precision. It's about knowing when and how to use a scalpel.
So, most of us probably think of vasopressin as our go-to second pressor in septic shock, right? The pipes are all leaky and dilated, but what happens when the problem isn't the pipes at all? What if it's the pump? The heart itself is failing. That's the big question we're going to dig into.
Here's how we're going to break it all down. We'll start with the main problem in cardiogenic shock. Then we'll get into how vasopressin works its magic, look at the actual evidence, create a kind of playbook for using it, and wrap up with a quick quiz to see what stuck. Let's do this.
Okay, Section 1, the cardiogenic shock dilemma. See, before we can even talk about using this specialized tool, we've got to understand why our usual go-to pressors, why they sometimes just aren't enough or can even backfire on us.
So what are we really up against here? Cardiogenic shock. It's just this brutal, vicious cycle, right? The heart fails, which means it can't pump enough blood to the body. So the organs start to fail, and that puts even more stress back on the heart that's already struggling. It's a downward spiral. And with mortality rates being so high, breaking that cycle is everything.
And this is where it gets tricky. Our standard pressors, the catecholamines like norepinephrine, they're great at raising blood pressure, no doubt. But how do they do it? They make the heart beat harder and faster. Now think about that. When your heart is already injured, already exhausted, that's like kicking a horse that's already down. Sure, you might get a temporary boost in blood pressure, but you're burning through its oxygen reserves and potentially causing even more damage.
And that's the perfect lead-in to our next section, vasopressin's unique mechanism. If the standard stuff has this major downside, what's so special about vasopressin? Well, it all comes down to how it gets the squeeze.
Okay, check this out. It's all about the contrast. Think of catecholamines, like norepi, as a squeeze and kick. They squeeze the pipes, sure, but they also kick the heart, making it work harder. Vasopressin? It's totally different. It's a pure squeeze. It works through a completely different pathway, no adrenaline involved. It hits these V1A receptors to tighten up the blood vessels. But here's the kicker. It does it without directly flogging the heart. And this selective action is a huge deal. See, vasopressin is great at squeezing the systemic circulation, that's the vessels going out to the body, that's what bumps up your overall blood pressure. But, and this is key, it barely touches the pulmonary circulation, the vessels in the lungs. Now, why does that matter so much? It means you can prop up the body's blood pressure without overloading the right side of the heart. That's a massive win. All right, so the physiology is pretty cool, right? But that brings us to the big question in Section 3. Does the data actually back this up? Let's take a hard look at the clinical evidence and be really honest about what it tells us and, just as importantly, what it doesn't. So here's the deal. Right now, using vasopressin in cardiogenic shock is kind of a tightrope walk. On one hand, you've got this awesome physiological theory we just went over. It just makes sense. But on the other hand, the hard data from big clinical trials, it's pretty limited and frankly, it's all over the place. So what does that mean for you at the bedside? It means your clinical judgment, guided by that physiology, is absolutely everything. And when you dig into the research, you'll see a common theme. There's no single giant study that says, yes, this saves lives across the board. It's just not there. Most of what we have are retrospective studies, which have their own issues. But, and this is a big but, hidden in that data are some really interesting signals. It looks like vasopressin might be a game changer for very specific types of patients. And where's the strongest signal? It's in the sickest of the sick. We're talking about patients who are already maxed out on high doses of other pressors. And what does that tell us? It suggests we're not just dealing with simple pump failure anymore. We've drifted into a mixed shock state. You've got the failing heart, yeah, but you've also got those leaky, dilated blood vessels we see in sepsis. And in that situation, a pure squeezer like vasopressin starts to look really, really good. So that leads us perfectly into the most practical part of all this, Section 4, the vasopressin playbook. This is where we take all that science and those hints from the data and turn them into something you can actually use at the bedside. It really is about matching the right tool to the right job. So let's start with the green lights. When should vasopressin be on your radar? When should you be thinking, maybe this is the move?
Okay, we've talked about mixed shock, but check this one out. Dynamic LVOTO. It's a mouthful, I know. It stands for left ventricular outflow tract obstruction. Basically, the heart muscle itself is so beefed up that it's physically blocking blood from getting out. Kind of weird, right? Well, in that very specific case, you want to increase the afterload, the pressure the heart pumps against, to kind of splint that outflow tract open. And what's a great way to do that? Vasopressin. It's a perfect targeted job for it.
Now, just as important, if not more so, are the red lights. We know when it can help, but when could it actually make things a whole lot worse?
Yeah, you definitely want to steer clear in that classic cold and wet pump failure where the SVR is already through the roof. Squeezing harder is just pointless. It's also a big no-no with a VSR. That's a hole in the heart wall. If you squeeze the systemic circulation, you're just going to force more blood through that hole in the wrong direction. And this is a huge one. If your patient is on an IABP or an Impella, those devices are there to reduce afterload. Vasopressin increases afterload. You'd literally be fighting your own life-saving equipment.
And this is where it all comes together. Think of this algorithm as your cheat sheet for the middle of the night. Let's just walk through it real quick. So you've confirmed cardiogenic shock. Boom. First big question, is there vasoplegia? Are the pipes leaky and dilated? If it's a yes, you go down the left side and it tells you to add vasopressin. But if the answer is no, if this is just pure, classic pump failure, you follow the right path, and what does it say? Avoid vasopressin. It's super clear. This is a great thing to have saved on your phone.
Okay, last section. Let's put this into practice. Time to test your knowledge with a couple of rapid-fire cases to see if this stuff is really sinking in.
Case number 1. Your patient is in shock, they've got an Impella humming along, but you still need more blood pressure. You reach for a pressor. Is it going to be vasopressin?
Nope, not a chance. This is a hard red light. Remember, the whole point of that Impella is to unload the left ventricle, to make its job easier by dropping the afterload. Vasopressin does the exact opposite. Adding it would be like hitting the gas and the brake at the exact same time. You're just fighting yourself. All right, next case. You've got a patient with severe aortic stenosis. They flip into AFib with RVR, and their pressure just tanks. Is vasopressin a smart play here?
You bet it is. This is a perfect green light situation. Why? Because you need to get that coronary perfusion pressure up, but the last thing you want is a drug that will speed up the heart rate even more. That's exactly what catecholamines would do. Vasopressin gives you that pure squeeze to support the pressure without the chronotropy, which buys you the time you need to deal with the AFib.
So let's bring it all home. Back to that first question. In the messy, complex world of cardiogenic shock, is vasopressin a sledgehammer or a scalpel? I think the answer is pretty clear. It's a scalpel. This is not your first-line one-size-fits-all pressor. It's a highly specialized tool for very specific jobs. For that patient in mixed shock, for those weird obstructive problems, and for any time you absolutely need to raise blood pressure without kicking the heart. Knowing when to pick it up, and maybe even more importantly, when to leave it on the shelf, that's the art of critical care.